We'll introduce you.
Okay, well, thank you.
Good evening, everybody. Welcome to TWed. Sorry if did everybody get pizza? Everybody got at least twice. Sorry about that. We'll plan for we've got a TWed next week, we got a TWed week after, we got lightning talks coming up. We'll plan for more. We'll order more. But so a couple of pieces of logistics. We have lightning talk sign up that I've sent out to the notice. Please sign up. Some of you have, most of you haven't. I think most people have participated or are familiar, but that's a lot of fun at the end of the term. We have, I think that's about it. Oh, the talk tonight is being streamed live and recorded for posterity. You're welcome to ask questions, but just keep in mind that it's recorded forever and ever. Thanks to Google, it will never go away. So, thank you very much to Brenda for giving our talk tonight. I think it's fascinating. I think most of you as well because you're here.
Yes.
Take it away.
All right. Well, thank you. Thank you all for being here, first of all. My name is Brenda Thomson. I'm a first-year PhD multidisciplinary science student. Just finishing up my coursework, so everything that I'm doing tonight has been done in the last year. So we have lots of places to go still. So anyway, so the story that I'm going to kind of deliver tonight involves uncertainty. There's a bit of history. Definitely some politics, and basically I'm telling the story through the lens of women's health policy. So kind of cover the agenda. So again, women's health. So I have a timeline and we'll kind of walk through some of history regarding women's health. And I'm going to roll out a small assumption. And we'll move to policy. And leave that, of course, with what work is left to be done in that area. Then we'll move to the data segment and what I've done with data and what that means. And I'll show you some preliminary results and then what work is left to be done there. So first of all, when it comes to women's health, I had to kind of take a step back and look at what my questions really were. And in this case, I was really focused on, do those policies that we fund with government money and research, do those actually alter the common causes of death in women? So as I kind of work through that, I mean, there really is a lot of federal policies. There's entire agencies dedicated to women's health. And so there's a lot of data out there, but it's not, I couldn't find it in any real cohesive way. So I had to follow through with asking if those policies are improving women's health in any measurable way. So let's kind of take a look at the timeline. This is a big part here. So first of all, I kind of need to explain that not all of my data and research falls into the same timeline. However, relevant work has been, or things have been done or have happened from 1960 until current time. So I'm going to start by explaining that most of, before we get to policy or data, there were social movements that were altering women's health and that led to policies being formed. There were social movements. There were, all of these ideas were really changing in the 60s. So I kind of start from the space of where the FDA, the Food and Drug Administration, approved the pill, which is contraception for women. So I start there. Something that became kind of foundational for women's movements was when the Feminine Mystique was actually published, and it encouraged women to start actually valuing themselves in terms of what they believe and how they're actually moving through society. Then we had some things like Supreme Court decisions. In this case, Griswold versus Connecticut was about actually allowing married couples to access and get approval to use contraception. The next big publishing item was Our Bodies Ourselves, which is still in publication today, certainly teaching women how to appreciate their own bodies and what exactly that means for their own health and their own lives. Then there was Title IX, which most people think of as, currently we tend to think of this as equal representation in sports, in educational situations. But the fact is, really the big contribution that this made to the women's movement was that it allowed women into professional colleges, professional arenas that they had not been before. And of course, there's the monumental Supreme Court decision of Roe v. Wade. And I guess that most people are familiar with that one. And then finally, it was in 1983, we're a little off here on that, but was the first comprehensive national survey on women's health. We hadn't really done a nationwide survey of women before 1983, which is rather shocking. So finally, and this is the Congressional Caucus for Women in 1989 started pointing out that the National Institute of Health was not conducting research on women, that they were being left out. So with that being said, I'm going to go into, this didn't show up so well, this section here is where my policy data comes from. So you'll notice there's a flurry of activity from 1993 to 2016. Starting with the Women's Health Initiative, which was one of the first NIH-funded studies. National Institutes of Health funded study, and it was a longitudinal study for 14 years, and actually is still ongoing. So it keeps getting refunded, which is a good thing. So we're keeping track. Big reforming thing that happened for women's health was the National Institutes of Health Revitalization Act in 1993. And what that did was it finally, for the first time, allowed women to be included in clinical trials. They actually kind of insisted on it. And so up until that point, women being included, not having been included in clinical trials, pretty much everything was assumed, you know, that sex did not make a lot of difference. And so they, so this changed all kinds of things in terms of funding, in terms of quality of healthcare, and what we could do with our research. So eventually, in 1993, the National Cancer Institute and the National Institute of Environmental Health Sciences funded the first large breast cancer study. Women had been dying, you know, at incredible rates at breast cancer, and unfortunately, we had never studied it on a national level before this. So then finally, this is where everything starts to happen really fast. So violence against women, the Act, Violence Against Women's Act, was actually passed in 1994, which for the first time gave women the right to, at the time, to sue their abusers. So this, of course, led to some tracking of, you know, data regarding what was going on with violence in women. And then at the same time, 1994, right after this study, the Long Island breast cancer study had begun, we discovered the BRCA gene, which is it's basically a genetic determinant of where your susceptibility is for getting breast cancer. And interestingly enough, immediately the following year, in 1995, we found the BRCA2 gene. Then came the Women's Health and Cancer Rights Act, which this was the first time as well. It said that if you're going to actually do mastectomies on women, you have to offer reconstructive services. So, you know, radical mastectomies had been going on at this point. That was the standard of treatment, but they didn't offer any reconstruction until this point. So also then finally in 1998, or no, 1998, the FDA, Food and Drug Administration, finally made a ruling also that when pharmaceutical companies are getting their drugs approved and running their trials, that they actually now have to make a distinction, thank you, between on the gender, what is the difference in how these drugs affect gender? Because at this point there had been women dying from drugs that didn't have that effect on men. The Breast and Cervical Cancer Treatment and Prevention Act in 1999. This one in particular allowed for Medicaid to cover breast cancer and cervical cancer treatment. So up to this point, if you were poor, you were kind of not allowed. Then I mentioned here the Mental Health Parity Act, because women are generally diagnosed more often with some mental health, and this particular act said you have to cover this. If you cover health insurance, if you have health insurance, mental health has to be covered at the same rate. So big deal for women. The Preemie Act finally said, oh, look, preterm births are a problem for a majority of women, or a large section of women. And so this was the first time that they said, we should probably start looking into why that happens. And that didn't occur until 2005. So next big one, the Affordable Care Act. And this one is like totally shifting for women's health, simply because the Affordable Care Act allowed for no co-pays or deductibles for just general women's health care. Items that we, have annually. This was the first time we were saying, yeah, you can actually get those regardless. So, good stuff. So, Preventing Sex Trafficking and Strengthening Families Act occurred in 2014. Its purpose was really just exactly what it says there. They were looking for ways to literally prevent sex trafficking and to start watching where these women fall, where these young people fall, and how they're affected. And finally, the Justice for All Reauthorization Act. This one was really important in 2016 because this was the first time, too, that they finally said, hey, we're going to fund so that all of those backlogs of rape kits can now be tested. So we had certainly had a national crisis over that. All right, so just a reminder. So those were policies just between 1993 and 2016. Now, the data set that I'm going to be using actually only covers the time frame of 2000 to 2015 inclusive. So I've got some dates that are kind of all over the place, and I'll kind of explain that as I go along. Now, here comes my big assumption. Okay, so I have chosen to use death certificates as a way to see if those policies are aligning, federal policies are aligning with women's health. But what I'm doing is I'm using death certificates as a proxy for health. And so to explain that, my basic question was, do policies fund research in the most common causes of women's death? And so to kind of explain this, basically, so we start with a policy. Usually social movements kind of inform policy, make policies happen, but we start with a policy. And that policy gets implemented, we have research funding, research creates knowledge, treatment protocols, things of this sort, which then get delivered to a practitioner. Practitioner delivers the treatment, has, developed some way, some methods to deliver that treatment, and watches the outcomes, and those are delivered to the patient. The patient has two outcomes. They either live or they die. So as an explanation for why I've chosen death certificates as a way to look back on women's health is this simple fact that patients live or die. So are we affecting that with our policies? And is one informing the other, to be honest. So let's take a look at some policies. So the big question was, what are the policies that affect women's health? And again, reminder of the scope. So when I did that, obviously, I think you saw I went through all of the congressional records and looked for anything that applied to women's health and what were those acts of Congress. And then I went and did a whole bunch of research, reading, which I'm sure we're all very familiar with. Kind of consumes our life. And my research, I've limited it to the United States. Again, for the articles themselves as they relate to policy, 1993 to 2016. And these are basically a list of the databases that I access. So PubMed, Elsevier, I think we're all probably pretty familiar with those. What I found was my keywords, kind of important. So they were women's health, health policy, women's mortality, and data-based women's health policy. And I will point out that when I said data-based women's health policy, almost nothing comes back. So I know what I'm doing is a little unusual. So I had 21, sum total, I had 21 articles. And what's interesting about that, this is what the graph shows actually, is that 43% of those articles that were published all occurred in 2016, which is a tremendous amount. So you can see how it's building to, we're really in this space right now of lots of influence. And also the Congressional Acts that I looked into, that I noted as being for women or have some effect on women's health, 4 of them occurred in 2014, which is 20%. So in doing this, I knew that I was going to have to kind of keep track of this information. So take this for what it, as maybe a tool you can use. I noted in particular the year, noted the title of the Congressional Act, and here I noted the policy type, because policies, there's many different types of policies. Wouldn't necessarily expect an economic policy to affect women's health, but yes, there are things of that sort. So we have health, we have social policy. And then I noted here the responsible agencies: National Institutes of Health, the Health and Human Services Department, Department of Treasury. So then the Social Security Administration plays a role as well. So and of course, one of my personal favorites is the CDC, which is the Center for Disease Control. So within the policies and articles that I read, there were these 4 themes. So basically the policy itself, common themes here were women in clinical trials, and the Affordable Care Act. They were just kind of mentioned across all of the articles. They were mentioned, there are obviously policies of Congressional Acts, so that was there. You could actually separate all of these articles, all of these acts, almost across the practitioners. So we had things like the nursing journals, we had the OBGYN journals, OBGYN being obstetrics and gynecology. And there were some medical journals, but then a large majority of articles fell into the sociological journals, as well as the social work journals. So women's health doesn't wind up into, in a strict journal. It's really spread out. So that kind of leads to where activism comes in. And in all of these articles and all of the policies, you can see where people's activism, led to the policies, and they're mentioned in the papers, and how the papers developed were all out of this activism. So that's been quite interesting. And again, because the 4th one being uncertainty, there's not a standard definition of what women's health means. And we have, so across the journals, it's defined differently. Across the articles within the same journal, it's defined differently. So certainly myself will need to obviously make a definition for what it means to me, but the reality is that there's no one thing that is meant by women's health. So they're certain across all kinds of areas in this. So policy conclusion, to close this out, these were the questions that I had on the original slide that I don't have answers for yet. So are policies aligned with mortality causes in women? So I don't know yet. So I need to finish out finding out how the policy cycle runs. I do know that currently it averages about 10 years from the time research begins to, get moved through the clinical trials and on to humans receiving the drug. It's about a 10-year cycle. So I need to analyze that. So let's take a quick look at the data. Yeah.
Before we go on,
yeah.
Just going back to that previous one.
Oh, wrong way. No. There we go.
So, in terms of implementation, and actually this also relates to that table that you had.
Mm-hmm. Right.
Can you say anything about what you were able to find about how policies, what they proposed to affect? Like how were they actually having some of that? What was what were they doing?
So you're looking for, so a lot of these acts actually come back around for reauthorization, right? And there's metrics built into them to measure how effective they've been. So there's a ranking. We have a lot of congressional hearings on this, but where you come in and the experts in that area are discussing what metrics they've measured and how that goes up against the policy to whether or not
that's the observable. But right. What I'm talking about is and that's important. That's a good point as well. What are you observing? What are you proposing to change? Are you changing, constraining, affecting? That's kind of what I'm asking about. The policy is saying do something.
Right.
Observe something.
Something. Yeah. That's
so the answer is that's always written into the language of the policy. And if this becomes a law, it's written into the appropriation for that, or it's written into the regulations. So there is a way to find it.
Okay.
So it's categorizing policies. I'm sure.
Right.
But there's some of the others we're going to breast cancer.
Well, yeah. What I'm saying. So if you have that in that table, that kind of what the general purpose of a particular policy was.
Right.
What I was actually getting at is sort of the being very geeky. The implementation side. It has to say do something, or do restrict, or cause to happen, and then there's. And then you have this something that's the metric that observes, which I think that should be. Did you actually have that?
No.
But that I have the observable as well. What are you actually doing? What are you trying to change? Because obviously you're trying to change something, or you're just waiting. Sometimes they do just wait.
Yeah, sometimes they do. What's even more interesting about that data is the agencies that are involved in the implementation.
Yes.
Because they go all the way from the Treasury to the Center for Disease Control. So why does the Treasury Department, who by the way is in charge of printing money and collecting taxes, have anything at all to do with women's health? And those vagaries you'll find inside the policy as it's written, and then inside the appropriation language for the specific year that policy was first told to Treasury to go implement. So all of this stuff is there. I haven't dug into it yet.
Yeah. Thank you.
So just also briefly on that slide, so you said it usually takes about 10 years for a drug to go into effect planning. Is there a reason to suspect that 10 years would be similar, we should focus on the policies to see if the policy is starting to have an effect?
That's it. That's what I'm going to get to, is that basically, yes, we're kind of looking towards, knowing exactly what that policy flow is, and then looking at that time frame to analyze the data, and can we match these up to follow a path for how long it actually takes for a policy to actually affect women's health without drugs having to be involved. You know?
To be honest, that number is anywhere from 0 to 50. And there's not really an average. It's easier to calculate the average length of time a drug spends between discovery and FDA approval than it is to figure out how somebody makes up their mind back a policy that gets written up that then gets put on the shelf that then maybe gets put into a law somewhere down the line, or maybe not, and then gets funded or not.
Yes.
So it would be cool numbers to find that.
Yeah. Hopefully, we'll get there. Okay, so the data I've collected. Again, main questions were from what causes do women die, and who keeps records on women's mortality. And again, the data here was scoped only 2000 to 2015. This data is fairly easy to access because we have an authority on death certificates, and that would be the Centers for Disease Control. And basically, they're in charge of the oversight, the collection, and the maintenance of death certificates. So they're the authority. They have a wonderful website. It's called CDC Wonder. And you can just kind of go there and wonder all the deaths, right? Wonder all through the data. So anyway, so currently where I'm at, because it is just the very beginning, my method right now has been to go get the data. Yes, Mark? Yes. Yes. The CDC provides the form and says, you know, so currently the CDC has 3 different forms, as far as we know. So there's a 1989, there's the original form, there's a 1989 revision, there's a 2003 revision. And so coroners, hospitals all have to use one version of this form. And I'll explain all the data that is collected within those forms, but it also creates problems within the data, knowing as to which form was collected where. There are. There's the International Classification of Diseases standards. So there's 2 different sets of ICD10 codes. One is particularly for hospitals and their inpatient procedures, not the ones we're using. The other one is for literally the classification outside of anything and everything outside the hospital. And there's 68,000 individual codes within that. So 68,000 potential diseases, causes of death, but every death certificate is supposed to have a cause of mortality. I'll kind of explain on that note, on that question. Thank you for that one. There is there's a problem in the death certificates that we're already kind of aware of. The way they are done, the way they are collected is not standardized, as well as the fact. So when we have things like, you know, a murder is committed, or we have a drug overdose, or, you know, a radiation poisoning, something like that, or maybe just something we don't know what killed this person, so it's under investigation. The CDC does have guidelines on when death certificates have to be submitted. So a cause of death might be undetermined, so sometimes that can go blank. And there is no process at this point in time for any of the death certificates to be updated. So once it's hit the CDC, there's no, you know, but again, they're in charge of them. So that's kind of, we do have, yeah. So anyway, I'll stick with that. So right now, the tools that I'm using have been RStudio, Python, and Jupyter Notebook, right? We're all pretty familiar with those. So again, just a real quick reminder that, you know, using death certificates as a proxy, right, for women's health. So talked about the Center for Disease Control. Let me kind of run you through the raw data. So basically, this is what it looks like when I download it. And mind you, there are 77 variables, so this is a very short, you know, I obviously did not include all of the variables. So in this case, so we have different types of resident statuses. There's a total of 5. You know, they have education standards. So on the form when you fill it out, depending on which form you're using, you have a different set of variables that you can select for. So, so with things like education, just because it's a 20 doesn't mean you've had 20 years of school. In some cases, that means that you've had 5 or more years of college. In some cases, it means that you went to high school. So there's a lot of coding variables. I have a monster of a code book that I have to read through to determine what each of these actually means in terms of how they're marked. One of the big things is the ICD10 codes that I was talking about here. That's okay. Well, anyway, so those are the 68,000 options. In this particular data set that I'm working with right now is 2015. So I have 4,000 of those 68,000 of possible. 4,000 of those codes are actually representing causes of mortality in the data. So there's things like marital status. We have, what month they died, what day of the week was that they died. Did this injury occur at work? We have, how did they die? Was it, what was the manner of death? Did they have an autopsy? What is their race? This is a big one because race is, again, not, in this case, not form dependent, but instead it is actually state dependent. So a state might have 5 defined races, which is common for, the CDC says, these are the 5 races. You've got white, black, Asian, Pacific Islander, and Native American, Alaskan Native. And then you can choose, and then it's either you're Hispanic or you're not Hispanic. And so some states have done things like, they've broken it down, are you Filipino? Are you, so it goes through this, more and more and more, and it's state dependent. So whatever their needs are. So it's a variable that actually has about 10 slots to, 10 columns in the data set that have to be determined as to where they belong. So, and race, as we know, amongst women's health is a big factor in what's happening, and you'll see that later. So anyway, so just kind of a quick overview of, it's a complicated data set. We are dealing with different forms. We have to determine which form is being used, so we know what's represented in the data. And, so frame of reference, that's 77 variables. What happens here is that each line represents a death certificate. So each year we have right about 3 million lines in every data set. So, and that's when we do men and women. On average, what we're seeing is about 1.5 million women. Right? Yeah, 1.5 million women in each data set. So 1.5 million lines in every year.
So are they converting ICD9 to ICD10 or?
There's a whole process for that. So this is kind of one of the reasons that I started at 2015 instead of 2000. Because of the 1989 revisions, the 2003 revisions, as well as the movement from the ICD9 codes to the ICD10 codes. If I develop the method and have a method down for 2015, it'll be easier going backwards because those changes, that was my thought. Just making those changes backwards will be a little easier.
Do they have agent death?
They do, yes. And that actually sometimes is imputed because the birth certificate isn't available or a family member isn't available to deliver that information. So there is instances of imputed data as well.
This would also include, by the way, any bodies that are found that don't have any identification, where they decide it's female based on the bones and the structure, and the cause of death would be unknown unless they can put out.
So we have all kinds of great stuff. So, so anyway, so what I'm doing currently is analyzing the mortality causes that I find within the ICD-10 codes. And I should kind of clarify, the ICD10 codes, actually, there's 68,000 of them, but it's kind of arranged hierarchically. So you actually have upper levels of the disease, with the uppermost level amounting to an option of 20 codes. So anyway, so that is, you'll see a little bit result of that later. Mainly, I'm looking at age, what are the ages of death. I'm really interested in the race factor to see where people are, where females are dying, and what is that separation of diseases that are killing them. There is not within the CDC. So I think as we go along, that might become more relevant, and I'll have to seek that data.
Is it not probably the state that issued each test?
Nope. Yeah. No, they do not. I think they consider that to be too much PII. Yeah. You could actually track somebody, I think, if you had that. So looked at, I should explain real quickly. Let me tell you, so along with the cause of death, the cause of mortality, they also have these elements of record conditions and entity conditions. So those are things I haven't touched on yet, but what those represent, the record conditions are literally what, if we know this person died from this disease and we have their medical records, what are those other causes of that they've already had diagnosed? So what are those diagnosis codes that are existing before they died from X, right? So there's a lot of data in those. There can be up to 20 on 20 conditions on just for record conditions. Same thing, same rules apply for the entity condition. So a coroner might make the determination that you died from myocardial infarction, and now, but you did have, you had dementia, you had, cancer, you had, and so even though those things may not have been diagnosed yet. So those are what, when I talk about entity, it's you as an entity.
So, okay, so they're both
code, yeah, all based off of ICD10 codes. So now again, I'm just learning ggplot, so you have to bear with me on this really basic stuff at this point. So what I did here is looked at female mortality. I'm referring to top 10, top 20 ICD codes. So I'll read those off. But anyway, so these are the races. So we have Asian, American Indian, African American, Pacific Islander, and Caucasian. So as you can tell, the majority of the data set is skewed certainly towards Caucasian females. You can see a little bit of Asians here, a little bit of the red. The amount of American Indians is so small that you really can't see it in this chart. I'm working on that with a stacked bar chart. So, of course, you can see a little bit of the African American playing out, and you don't see the Pacific Islanders represented either. So basically, what happens here is this is women. This top number is 400,000. So in 2015, this is just I should clarify, this is just 2015 data at this point. Over 400,000 women died from circulatory diseases. So circulatory, literally the heart is involved. So this is where your heart attacks fall, your myocardial infarctions, all these kind of things, COPD. And then the next large killer here is neoplasms. We know them more commonly as cancers. So cancers of all types fall in here. Then comes respiratory diseases and nervous system diseases. So we'll just kind of stick to the top 5 on those. But so that's kind of, so I don't know. So there's a huge difference in circulatory diseases even to neoplasm. So it's a big drop off. But again, we're talking about 1 million, and in this case, it's 1.3 million women. And knowing that, over 400,000 of them died from circulatory diseases, we should see a lot of funding, you would think, feeding that. So then I went ahead and broke it down to the lower level individual ICD-10 codes. And I apologize, I didn't get a chance to type out essentially what these are. And so basically, different scale only goes to 70,000. So what I did was looking at the individual ICD-10 codes and those direct causes of disease. What was revealed was that even though circulatory diseases are the most common, common cause of mortality in women, and as you broke it down to the individual codes, G309, the first one here, is actually Alzheimer's. So more women individually die of Alzheimer's disease than, in circulatory. So it kind of makes you second guess, right? But it depends. So what we learned from this really is that depending on how you look at those ICD-10 codes, depending on how you're analyzing that, definitely determines what can be those leading causes of death.
So is this, sorry. Is there any overlap? Like, do Alzheimer's patients also have breast cancer?
That's where those entity and record codes come in. And I have not gotten to those yet. So that's where that data will be hiding.
That was essentially my same question.
Yes.
Are you, is this total the first, second, third?
Right. No, this is just the cause of mortality. This is the listed cause of mortality. I have not addressed those record or entity conditions yet. So again, just very preliminary. So just so you know, going across these, it goes Alzheimer's, ischemic heart disease, just a second. Then we move to organic dementia, which is actually a mental and behavioral, is where that falls. The fourth is lung bronchial cancers. And then chronic COPD, chronic obstructive pulmonary disease. So again, with the heart and the circulation. Next comes acute myocardial infarction, again, circulatory systems. Then comes breast cancer. Then stroke, congestive heart failure, and round out the 10 is pneumonia. So have not done that yet. I think depending on where this goes, I think there might be some relevance to show the difference in how things are funded for the overall population, because generally things aren't structured, just funding for males, that's the whole group. And then there's female funding. So again, a little, I don't.
Currently, the future work that's out right now, it's a nice thing to know eventually.
Yeah.
So I would imagine that because death, all like you said, 60% of men, and then that's where it's going to be done in breast cancer.
Right.
So I think you have to have some level of comparison to see responses.
Well, if you're asking this question, how well does policy as a whole align with death? And yes, where we're going first, how well does policy funding for female health along? And then the next, your question is broader.
I was going to say, to be honest, I'll speak frankly. Right? The base assumption coming in is that there's a bias. So, and my own bias could be biasing that bias. So,
there's a report that the National Academy of Sciences put out in
2010
that effectively answered your question already, which is yes, bias of funding that comes out deals with health as it manifests males and not in females. And so part of the question is, well, are percentages actually going there? And they've already identified bias as a very large
problem.
Problem.
Yes.
So my question
Yes.
is, when it comes to the how, my question is, how, what's the difference between if they're actually doing male policy versus general policies, male policy versus, like, you can't just compare male policy versus female policy.
Correct.
All policies, male policy.
Correct. Correct. Yes.
Correct. Up until the first set of policies that she put on her timeline, the health policy was geared toward men. And the thing about the FDA, or the thing about women showing up for the first time in clinical drug trials is actually a regulation that had to be put in. And if you read the text of the decision on that, it reads like, well, it would, right now our statistics are skewed. We need better statistics. So let's put women in.
That's that was honestly, and this was the president of the president of the National Institutes of Health making a statement, Dr. Bennett. Just said, yeah, it's kind of skewed. And so yes, and so to speak a little bit more to that, what's currently happening in clinical trials, what the latest review of them said is that even though women need to be included in clinical trials, part of the National Institutes of Health Revitalization Act of '93 said, you have to keep this information separate for what's occurring in women and minorities. And the fact is that that's not really occurring. They're still seeing that is not occurring. And most of the researchers are saying it's too expensive. It's too expensive to separate out the data on women and the data on minorities. That's just too much classification.
Why is the disparity so, that doesn't seem
representative?
Yeah, that doesn't seem like a representative population. Why?
Okay, so one of the things to know about death certificates, especially in regards to race, it's absolutely going to be skewed towards Caucasian. And that would be simply because if there is not prior data provided, if there is not a family member to step up and say, we're of Asian American descent, right? It's literally whoever is filling out the death certificate looks at the skin and says, yep, Caucasian, or, So there's not a...
There's also, this actually came up in our meeting when she described on, there are nationalities who live in the United States, like I'll put on Egyptian. That classification for racial purposes is Caucasian. So you're going to see more Caucasians than you're going to see.
Yes.
Yeah.
Yeah, so it is heavily skewed white female.
Unknown might equal Caucasian, yes.
Yes.
Or not one of these.
Southeast Asia, Southwest Asia is also Caucasian.
Yes. Yeah.
Yeah.
Yeah, so it winds up being,
Caucasian doesn't mean white, it was not one of those.
Right? And one of the other things too is I moved towards I just moved towards Meryl's house, but like in terms of sex, again, one of the issues that we haven't dealt with yet, but there's I see some future work for as we move along. For one of the things that's totally lost is LGBTQA information just falls right off in the death certificate. You get A or B. So. And that may not be representative of how they live their life.
So it's already well on race thing.
Yes.
You mentioned that
Categories. That's included in the code book.
And I know overall, periodically revise.
Yes. Yeah.
And then also lose what was
the
my question is, has it changed?
right now from 2000 to 2015, there has not been great movement in that. Yeah, that's very good. Yes, but still has its limitations.
But then how did you there
okay. The Census Bureau actually has a description of what is required across all government agencies for what is race, what race are you, and they actually are the ones who assign these 5 races and then Hispanic or not. And so, but even on the Census Bureau, in the Census Bureau policy, it literally says race is self-identified. So, you know, right. So even, but it actually the Census Bureau is the one who sets that.
So the coroner going up, that's a checkbox.
Mm-hmm.
But there in some states they have different checkboxes than others.
Correct.
So how does that get reconciled?
Actually, they have a coding system. What's that? Yeah.
It goes
So-
up, the death certificates go to the state level. All the reconciliation that has to happen goes there, happens there, and then numbers and data are reported to the CDC. It's not like you mail a death certificate to the CDC. You get an aggregate at the state level and then that aggregate at the state level.
Information kept.
Not at the CDC level. Yeah, I have not looked to see what's available at the state level. So, you have a question?
So with this particular analysis, if you were to try and bring this towards policy, what level of granularity do you think is most appropriate to sort of change that policy, right? So in the last 2 slides, you're showing us like one very broad scope of many very wide categories. And
Right.
There are entire companies that target just one part of cardiovascular issues.
Yeah.
Right? So like pacemakers, defibrillators. There are pharmaceutical companies that make blood pressure medicine and stuff. So in terms of bringing this analysis and policy, what level of clarity do you think is most appropriate, or is that a question that you still?
That's actually actually ending. I have this slide explaining that. Yeah, that yes, I'm in that space of, as we kind of see where the data aligns across each other, and I still have so much data collection to do. But we'll see where it aligns across the two mortality versus policy. And from there, we'll have to make a determination, but it's really not clear yet. So here, they actually have some major causes of death, or manner of death, right? So interestingly enough, you'll find that most people die of natural causes. The colors aren't showing up real well, but so yeah, this is your natural causes. Here, it is not specified, and also pending investigation. This is like color. Here is where you're going to find accidents. I'm going to bet that if I did zoom in, this accident number would be higher. And this is, you'll notice that accident actually also is above the external causes of death. Right. So other than that, you really don't see any undetermined. Suicide again falls under the external causes of death. So those are the categories: accident, homicide, natural, not specified or pending investigation, suicide, and then undetermined. And I will note that in 2015, we actually have one particular case that has no cause of death. So the form was either not filled out correctly, didn't get read correctly, but yeah. Right, person woke up. The zombie apocalypse is happening. My data. No. Now my research has way more value. Right? Okay, so work to be done. I need to find a data set for policy funding. So, yell at for all of these acronyms. But basically, I do know that the National Institutes of Health is kind of originally where the money is funded through, comes through, I should say. The National Science Foundation, the Office of Research on Women's Health, as well as there's an actual office for the Violence Against Women's Act, and they sponsor all kinds of research as well. I need to look at, I'm going to obtain the data on how money is spent. This is kind of included in some of their annual reports, so it'll be a lot of scraping from PDFs and hoping that they're machine readable. And then, as we were talking about earlier, analyzing that policy money to the mortality causes, explore how that pathway works, and determining whether or not we need to start looking at other factors in women's health, like in their life, in their lifestyle. Do we need to start considering all of those factors to actually make this valuable? And then we'd like to essentially look at as a way to inform policy is, so the research funding and ultimately in lining out exactly how this will flow or should flow, or what it is now, what it is not. We're kind of hoping by explaining a return on investment and figuring out what that is, what is that length of time, what does it look like, can we shorten it, all of those things. So might actually help to inform policy.
So your goal is to look at actually either how long or if a particular policy has an effect on mortality, or
yes,
in a specific cause of death that is related to the policy.
Yes. Yes. Yes.
So trying to think about that's actually one reason why I was thinking that the age would end up being important, because you can actually use the age to do a Kaplan-Meier survival analysis.
Kaplan-Meier. Oh, okay. I know that. Yes.
Yep. Basically, what you can do. Actually, what you can do is kind of year by year, after the policy is implemented, you could actually do not just a single curve, but basically a surface of when the distinction in policies.
Awesome.
How do you make it so what proves enough to be action? This is the thing. So I see where this is going. Right, but this is it's a beautiful course. Okay,
right.
But you gotta overcome the standard of white guys.
Exactly.
People fund or don't fund clinical trials and things get through the FDA based on things like survival analysis. That's
but I guess so. I'm a little extremist, but the point is, how do you really? I guess that's the whole thesis.
That's right. That's the whole thesis.
Right.
Right. It's how it got funded in the first place. To be honest, it was women's activism. It was social activism that got that finally got the National Institutes of Health Revitalization Act. So that's how women became included in clinical trials where we were screaming. And I'm sure this will be a similar pathway. 1993. President Bill Clinton signed that. Yep. Hold on. Let me see.
How do you implement all this? So, the whole, I go to the doctor and I say, this is wrong, and the doctor says, oh, you're just crazy, you're just, whatever.
He literally says, here's your antidepressant.
Yeah, and then 5 times later, and they're like, oh, so this is all wrong, by then it's too late. How is that?
I say, no, this is a really good question because it's also very personal. But the fact is that through all of this, I think more than anything, what we have to do learn to do what we have to share as women is you have to go in educated, and you have to approach, we have to teach these behaviors that you go into the doctor, that you're as educated as they are. You respect their expertise, but they need to respect yours. It's your body, you know it. So that kind of social activism hasn't taken off. But I mean, the thing is that the whole system was built around males. So so it's not going to be a quick or sudden change. Certainly, it's something that hopefully by the time your generation is done with medical care, there will have been some serious changes in the sexism that exists.
The informed populace, your point about that really making sure that everybody has access to the facts and true facts and figures so that they go in.
Right, and the thing is that this is why the 1993 Act was so important. It has everything to do with the fact that there wasn't data on women. So we're only still really dealing with data since 1993 on women. So women go into the doctor right now, and the data just doesn't exist on you as a woman. So that's really a problem.
I wonder also now you were talking about those like codes, was it the energy, the comorbidity essentially, like what is the disparity between what was diagnosed for that woman and what they discovered she had after she died, or if she had something that was not diagnosed that ended up killing her, and things like that. I'm curious to see those results too.
Yes, I'm chomping at the bit to get to that part.
Because we as a developed nation,
let's see if I can get that.
Any point that
There's actually okay, you can't really see it here, but pregnancy and childbirth. There's an entire code dedicated to an entire code section dedicated to women.
So if they die because they had high blood pressure that the doctor died from a stroke, where does that?
Actually, this is kind of one of those unique areas. This is where women are definitely segmented. So if you die within 40 days of a pregnancy, of a birth, so 40 days either side, that gets marked down under pregnancy and childbirth.
What about miscarriage?
Same thing.
Okay.
Yeah.
That would be the child.
No, but if you suffer miscarriage.
The upper level that it falls under winds up being pregnancy and childbirth. Right. Correct.
When you look at the codes, the ICD codes, high level, you'll see distinct labels, but when you look underneath, you'll see things like heart attack or stroke or something showing up under multiple high levels as pregnancy-related stroke or So it depends on. That's why we're doing the deep dive as well as the problem, because the deep dive shows, as in Alzheimer's being the single leading cause of death of women in the year 2015 in the United States, according to the records, does not show up in the top 2 or 3 high-level codes because it sits somewhere else.
Yeah.
So I wanted to
Yes.
analysis you mentioned.
Sure.
And basically it's that Katie become your best friend with regard to the data. He is working on something called a semantic data dictionary, which is a way of dividing a true interpretation of complex data.
Okay.
So,
all right.
A lot of
Cool.
I'm trying to find ways to, for instance, straightening out the race and education level issues.
Interesting.
Your ontology has been developed specifically to address some of those things that provide representations against complex academia or data.
Okay, great. Because let me tell you, I've got like that many lines of code to get the race down into 5.
Well, that's
Great, exactly. That'll fix it. Oh. Yes. Oh, yes, absolutely.
It's more than just from code. It's being able to
Yeah.
Right, yeah, absolutely, yeah.
Are limited ICD-10 into categories that are actually aligned to expect them to be, essentially, trying to basically taking the analysis at the right level, but doing it fairly quickly to right service to do everything.
Yeah. I get, you know, I didn't do.
Dungeons and Dragons.
If I didn't have to write so much code.
So the other point that she didn't make, which is something we're going to have to deal with at some point, is Alzheimer's as a cause of death did not exist at a certain point in time because it wasn't known about, and it is only diagnosable through autopsy. So at some point when we do the longitudinal work, there's going to be 1 year it's going to be dementia or something else. The next year, all of a sudden the Alzheimer's deaths are going to go through the roof.
So
why? Because now it's a diagnosis. So when you have a spike like that, we're going to be really interested to see when there are spikes like that, when diagnoses change and when causes of death change to match the diagnosis.
What's that?
If it's unnatural,
The family can elect.
or the family has.
Family can elect. Yeah. Sometimes.
It may be
Things-
confirmed that, yeah.
Yeah.
If you've got a really interesting rare disease, then we'll do a proxy just to see what's in it. No.
It is not the default. No. They actually, that's the standard on across all of the death certificate forms. It's basically yes or no. Autopsy performed. So, but I should clarify too. One of the important things I left out was also that when I say women, I don't qualify that in the data set if you're female and younger than 10. So, because that data is not included.
But if you're not really, if you're not well, what if you weren't born?
We have no
We have no way of knowing that. That's the issue with the death certificate as well. That when it comes to sex, you can be male or female, and so that was what I was explaining about the LGBTQ information. It's just lost. All of that information is lost. However, I do know in the case of a transgender, assuming you've undergone complete, reassignment, sexual reassignment. I hope that's what they call it, right? As long as you have your birth certificate changed, then the death certificate will reflect birth certificate sex.
Unless like you're go and change it against your will or
right? Or.
Can you get the gender and birth certificate changed?
Yes, you can. You have to have some medical, I know in New York State, you have to have medical backing before you can do that. But once you've had a doctor sign off on it, yes, it can be done.
It depends on the state, I believe. There's some states that require
There you go.
like sign proof that you have the diagnosis or something like that. And others
Sure,
like
that gets your loss on that.
Oh.
surgery, or you have to take the hormones. But it sort of depends on the state. But I guess if you have a woman or a man who is taking hormones or something and that somehow leads to death, that would not be captured at all.
So no, it's okay. I just wanted to get Brenda's applause on recording. So let's all thank Brenda.
Thank you all very much.